Hello. Hi, everyone. My name is Elaine Wang. I'm one of the glaucoma specialists now in a private practice called Harvard Eye Associates in Laguna Hills, California, Orange County. And I also volunteer teaching at Stein Eye Institute, UCLA, which is where I did my residency. So today I'd like to talk to you guys about the Micropulse TLT laser, which I think it's a great tool that everybody in your comprehensive practice or glaucoma practice should add to their glaucoma treatment toolkit. So before I go into details about the Micropulse laser, I'd like to just kind of review how I get to using Micropulse TLT laser pretty frequently in my practice. Well, during residency, when I first started treating patients, the traditional cyclophotocoagulation is really what we were taught and used in blind, painful eyes. And that's pretty destructive laser that we do to the eye, use very high energy, and you titrate to that pop, and then you kind of come down from there in terms of the energy. Those patients we select for those kind of destructive surgery is really those that don't have very good visual potential. Years went by in fellowship, we transitioned to using the G-probe continuous wave that's using the iridex laser. And in this setting, we use much lower energy in a continuous wave treatment setting where we had really great outcome in patients even with very functional vision. As well as 20/40, 20/20 vision, we've tried these lasers on them as a primary treatment or secondary treatment after their other glaucoma treatments. It works great. However, I still encounter some significant inflammation in patients undergoing these treatment, especially in heavily pigmented skin or eye, and also people who are more prone to inflammation like mild uveitis. Sometimes we try it in there too. So after that, I think it came 2021 when Micropulse, the P3 probe really came around with the iridex laser, and where I started using more of the TLT treatment. Initially, I think everybody, when this new probe came as a modification to the P2 version, a lot of people were under-treating. We were definitely using too low of energy power and shorter treatment duration, or even the sweep speed wasn't really optimized. So I was getting really non-optimal results, not really compatible to what I was doing with the G-probe continuous wave. So I sort of took a pause there to kind of step away from Micropulse. But then after really more and more glaucoma specialists and comprehensive doctors using it more, optimizing the power and the treatment velocity, the duration, after several consensus, I think, with the Micropulse laser, we really reached now an optimal laser power setting and how you should use the laser to treat glaucoma for all stages, all ages, and all types of glaucoma. That's pretty much what I do in my practice. So what Micropulse TLT is, it is a non-incisional laser procedure that I often do at an ASC setting, but I know a vast majority of physicians also do them in the office. It is using a repetitive pulse of 810 nanometer light to treat a wide range of glaucoma types and severity. What I like about it, just to highlight the features of it, is it's repeatable. You can do it more than once or twice because it's not disruptive or burning any ciliary body off or kill any of those cells there. It's repeatable and it's titratable depending on the severity of the disease. I do titrate how much I treat from the power setting as well as the duration of treatment, and with a very favorable safety profile. I haven't seen any significant vision loss. I haven't seen even any significant CME as a result of my Micropulse treatment. It has minimal patient downtime or disruption, without any impact to their quality of life. I definitely have younger patients who can take time off after surgery to be down for a month or two without doing any of the heavy lifting, bending over, things you don't want them to do after incisional blood forming procedures. I have elderly patients who are on blood thinners who can't afford to, do any of the physical restrictions as well. And it is a great selection for people who had prior glaucoma surgeries, including angle surgeries or bleb forming surgeries, as well as even before that. So I do use the Micropulse as a primary treatment for some milder diseases as well. So this is to really highlight this is a very patient-friendly procedure that you could be using at any time when you scratch your head and think, what is the next step? It's never hurt to think of the Micropulse laser. So the Micropulse laser, the TLT, or transscleral laser therapy versus the CPC, it's not cyclodisruptive. So it targets the tissue slightly different from what the traditional G probe targets. It's not at the pars plicata, where it's the ciliary body that's making the aqueous. It's really targeting more at the pars plana plane, where we think the proposed mechanism of action is to actually increase outflow versus reducing the production from the traditional way of using the cyclophotocoagulation. So we think it targets both at the TM level, where then downstream the scleral, the Schlemm's canal and the downstream collector channels, as well as the uveoscleral pathway. So increasing outflow is really what we think the Micropulse TLT is doing for the eye to reduce eye pressure. So overall, I think to kind of summarize the benefits of the Micropulse laser is that it does not disrupt any tissue. It lowered the total energy delivered to the eye compared to the traditional G-wave continuous wave treatment. And it fit the entire glaucoma severity spectrum. Like I said, I'll show you some examples later where I do them in ocular hypertension, mild to moderate, severe glaucoma, or even some of my secondary glaucoma patients. And like I said, it can be used in many different types of glaucoma. So just to show you what's good about this new revised P3 version of the probe, it changed the tip of the probe a lot more than before, where it is definitely matching the scleral curvature a lot better than the G probe. It has that two bunny ear, where I call the bunny ear point towards the limbus, that really helps you to align the probe a lot better. And the fluid coupling channel really basically enhance the tissue coupling and better energy delivery. It because of the change in the curvature, now it can be really flush and flat on the eye because it fits the curvature of the eyeball, and as a result, it's much easier to maintain pressure and sweep velocity, and therefore increase and also increase the surface area for stability when you actually move the probe on the eye. It's ergonomically a lot more friendly. And with the recessed fiber, there's more perpendicular energy application to the eye directly to the tissue area where you want it to go to, and therefore, as a result, it has more consistent energy application. So the next question you may all ask is, how much are we supposed to really treat with the Micropulse TLT laser? So I think the studies there are many studies actually published about the Micropulse laser, and a review of all those publications, basically like a meta-analysis, reached a conclusion that if we want to achieve a moderate amount of IOP reduction, about 30% is the definition, you really want to deliver the energy ideally between 110 and 150 joule. So if you go below that, there's much higher chance of a failure. So you may need to repeat the laser, or it just doesn't get to the 30% reduction you want. If it goes much higher than that, above 150, or actually I would think much higher than 150, there's a lot more chance that you could cause complications in the eye in terms of much higher rates of inflammation or lower in visual acuity. With newer and newer studies coming out, and also glaucoma specialists doing this more and just based on their experience, personally, I also agree that that number is probably more leaning towards the 150 and not the 112. And I even went above 150 and still get great results, but definitely not as high as 200 or more. So to calculate the total energy delivered to the eye using the Micropulse laser, it's really three parts of the equation. It's where you set your power to be at, or in the duty cycle, which is pretty much standardized as 31.3%, and then it's how slow you deliver your energy. And if we keep the power constant at 2500, it really depends on how many numbers of swipes or treatment you deliver to the eye, and then you calculate as a multiply this different numbers to get to the total energy. So as you can tell in here, it's basically trying to show you a very simple idea: is the more you treat, the number of sweeps, the higher the number of sweeps, the more energy you deliver to the eye. So if you set the energy power at 2500 and at 20 seconds per hemisphere, or if you do quadrant, 10 seconds per quadrant, as you do 3 sweeps, you get to about 94 joule. If you do 5 sweeps, you really get to that sweet zone of 157 or so joule. In another way of looking at it is if you keep both the number of sweeps constant and the energy constant, the slower you treat, the more energy you deliver to the eye as well. So this is a simple math to show if you do 10-second sweeps, you increase that to 15, you really increase another 70 or so joule to the eye. If you go even slower from 15 to 20, then you really actually increase that total energy delivered to the eye to about 305, which is getting to the zone where we think it's a little too much for the eye at this point. So I usually go somewhere around 15, and I do about 4 sweeps or so. And I can show you, this is my typical initial setting, is depending on the severity of the problem and what the patient had done before for their glaucoma treatment. I keep the initial power at somewhere between 20 to 50 to 2500. The 31.3% duty cycle is pretty much set. I don't change that. And I do 15 seconds per sweep and 4 sweeps. So total about 60 seconds per quadrant or 120 seconds per hemisphere. I just personally think doing it per quadrant is more ergonomically friendly. I can move my body and the probe more easily on the eye, and it just gets me better contact with the eyeball and better results. So this is just to show you, if you do it per quadrant, you do the superior, inferior, or you can do the nasal temporal depending on where you position yourself with the patient. If you're on the side, you can actually do it temporal and nasal as well. But the idea is you do 112 seconds per hemisphere or 60 per quadrant at 15 seconds per sweep. So that's a 4 sweep treatment basically. So just some key points, some tips that you could probably take away from this is good coupling agent is very important. I use the lidocaine gel, which helps to numb the eye and also serves as a good coupling agent. The gentile gel is something else that people use. Gonio saw is another thing that you could use, as you do with your other lasers. The bunny ear points towards the limbus, where if you align that, you're going to be arriving at the right distance to treat with your laser. Consistently apply a pretty stable and firm pressure onto the eye, but don't push too hard. Make sure you're not floating on the eye, but have a very firm, you can tactile feel the very firm application, and go slow. The laser does count down anyway. It counts in 10-second increments. So it tells you it's 10 seconds, 20 seconds, 30 seconds, 40 seconds. So for me, if I do 15, I do need to count that 5 seconds myself, or have a tech tell me. So just to go over some typical cases that where I use the Micropulse laser. The first case is a Micropulse TLT in an ocular hypertension patient. This is an 85-year-old Caucasian male with just ocular hypertension with really no capping or any change in his visual field, but his pressure has been consistently above in the mid-20s. Previously, he was controlled on Vyzulta once a night, and the goal pressure is to just keep him under 21, but he eventually developed an allergy to the drops and really begged me to get him off of any topical treatment. So he also says that, well, if I doze off at night, I really don't use my drops. So you really don't want them to get into the habit of a compliance issue, and the pressure fluctuating from one day is low, next day is high. I don't think the nerve really likes to see fluctuations like that. So because he strongly desired, and I think he can be controlled with the Micropulse laser, or I say a laser treatment that's non-topical, we initially actually tried in an office SLT. Unfortunately, he didn't really get great response to the SLT after I removed the drops. So after 3 months of the SLT treatment, which I think we've waited long enough to see the SLT has failed, a month later we did the Micropulse TLT treatment. So I set it as 2250, 90 seconds per hemisphere, which is lower than my typical setting, but this patient also is just hypertensive. The goal is 21, not too aggressive. I did a slow sweep at 15 seconds, 6 sweeps per hemisphere, and then just to show you, he's pre-op pressure 18-20 on Vyzulta once at night, and afterwards basically I got him to 16-18 at post-op month 6 off drops. So if you look at the absolute number, it's only about 11% reduction in the right or 10 in the left, but from his baseline, but this is completely off drops. So if you consider that part from the actual, we didn't do really a washout period, but if you look at that from where he really came down, it's definitely more than 30%. So his pressure is well controlled now, visual field is stable, and vision is pretty much intact from where he started with. He's very happy. If there is a patient testimonial video, I'm sure he'll be the first volunteer to be in part of that. He thanks me every time he sees me, no more drops. So the second case is a Micropulse TLT treatment in mild to moderate glaucoma. This is a female who's older, in her 90s, and previously also had pressure controlled on just Zalatan once at night, and her goal is about 18. We tried, so her pressure came up, and her visual field is progressing slowly. Initially, we tried to escalating her once a night treatment to other daily dosed topical treatments like Vyzulta or Ropressa or Rocklatan, but that became financially a little too challenging for her, and also given her much older age, it was difficult for her to apply her drops. So she decided that if there is an option for her to not have to use drops, she would want to do that. So her pre-op vision is pretty good at 20/40, 20/25, pressure's 22/23 at that point on Zalatan, not controlled. So we did her Micropulse setting at 2250, 60 seconds per quadrant, so 120 per hemisphere, 15 seconds slow sweep. So besides the 2250, which is a little lower than my typical setting, this is pretty typical where I start with the Micropulse laser treatment. And so post-op, her vision is pretty much the same. Left eye is a little bit better even, but her pressure then is at months 1 is at 16 and 18 off all the topical drops. And again, even though it's around 10 to 15% reduction from the absolute number because of no washout, actually if you consider where she came from, the higher 20s number, it's closer to a 30% reduction. Her post-op vision was stable. I do macular OCTs on these older patients just to see if I get any CMD. So far, we haven't seen any significant inflammation, and her pressure is very well maintained. Next case is on a severe glaucoma patient. This is a patient, 76-year-old male with severe POAG, where his target pressure really should be closer to the lower than 13, so 11 and 12. Weren't able to really get to that goal when he was maximized on all available topical drops. He knows that he needs incisional surgery. A tube or trap probably is coming his way, but he's also the main caretaker for his wife who's undergoing some ortho treatment, and he does a lot of heavy lifting to lift her. So incisional surgery wasn't looking like a good option at that time. I just do not want to deal with that subchoroidal hemorrhage if he has to strain himself all the time. So we decided that maybe we could try the Micropulse laser to at least get his pressure lower while we wait for the recovery of the wife, so we can actually go into the operating room and do more incisional glaucoma surgery. So his vision is actually pretty good at 20/40 OU, and the pressure is 22/18 on all those maximum drops before the laser treatment. So his setting is definitely pretty typical, exactly what I would start usually. So 2500 at 60 seconds per quadrant, 120 per hemisphere, basically 50-second very slow sweeps. So that's 4 sweeps to get you to 60 seconds per quadrant. And then afterwards, his vision is excellent at 20/30 or 20/25, arguably a little better than before the surgery. And then he achieved 50% reduction from his baseline on the exact same drops. drops he's on. He's still on drops. We get him to where he needs to be at 11, which is under his gold treatment as well. And we're just basically holding him off until we can really do more permanent surgery, which now I feel much more comfortable waiting on. Next case is a Micropulse TLT that I used on a patient. I did a tube surgery before. So this lady was MVG, and I did a med glaucoma implant and FP7 model. Her goal is to get to 13. Before that, she was controlled on Ropressa and Timoptic. However, she developed pretty severe allergy to Ropressa, and also financially that's a little too much for her as well to use, a brand name, also a preservative-free version of the Timolol. So she's asking whether there's some way to help her as well to be better controlled. We actually tried Cosopt, Compigan, all the other different available topical treatment. She's very prone to allergy, so that wasn't a good option. And she also has a history of BRVO CME, so PGA wasn't the best idea either, and we had actually seen PGA exacerbating her CME, so we had to go with Micropulse laser. So for her, I started at 2500 and typical setting, 4 sweeps, pretty slow sweeps per quadrant. And then I actually placed the probe directly onto where the tube was going into the eye, so not avoiding the area where the tube was going. I would be very cautious if it's a trap, but based on my experience when treating these patients with the tube in the eye, actually you could go right over it, and I think it made the tube actually works better afterwards. I don't know why, but that seems to be an anecdotal observation. It does not burn or disrupt the conjunctiva, that's for sure. And afterwards, she was able to get to a pressure of 12 on just Xiop-10. So we achieved about a 14% reduction in her pressure, and now she's down to just one single agent. Other scenarios that I would consider using the Micropulse would include in traumatic glaucoma and steroid responders have good results on those as well. I do use it very carefully in mild uveitic glaucoma with inflammation very well controlled. Neovascular glaucoma, like I showed you earlier, after their tube shunt, and I use them in chronic angle closure glaucoma as well. Though the settings for chronic angle closure glaucoma, I tend to go more aggressive or switching to the G probe, which I will talk to you later about. So the basically, just to give you an example of how I use them in the secondary glaucoma, this is a 78-year-old with pretty moderate damage in the visual field after blunt trauma and multiple retinal surgery following the blunt trauma with retinal detachment. His pressure was uncontrolled on also all the drops available, and then he has a body shop, and he wishes to delay incisional surgery as much as possible because he doesn't want to give up his work working with the machineries. So, door. I did 2500 power 60-second, my typical setting on this patient as well, and he was 18 pre-op on maximal treatment, and later on, and his goal is about 15, and afterwards we were able to finally get to 13 on just 2 topical medications minus the bromonidine that she was on before, and that achieved close to 30% reduction and 1 less medication. So he's happy now. He's just waiting also. Maybe he's going to look at an incisional surgery later, but at least we also bought him time to get him to do what he wants to do. So kind of a theme that going along all my cases is that I really like the fact that this is very patient lifestyle friendly. There is minimal post-op downtime, so you really have the physical restriction we typically have for even now angle surgeries. If you do a 360 goniotomy with a GAT or Omni, you worried about that hyphema. You also don't want them to really strain themselves after the surgery, so that restriction really deterred a lot of my patients who want to go forward with surgery, but Micropulse at this point is a really good option for them. They don't have to take time off from their work much. The elderly patients, when they are the only person taking care of themselves, also would welcome minimal post-op restrictions, and also the follow-up. I usually see them I still see them post-op day 1, but I know a lot of my glaucoma colleagues don't even have to see them post-op day 1. And then there's the optional probably week 3 that I do, and then post-op months 2 or 3, depending on where their pressure is and how much inflammation I'm worried about. Definitely not as intense as the incisional filtering glaucoma surgeries. So because of this very reason that it's post-op very friendly, a lot of my patients really welcome this laser. So like I already told you in my cases, it is a great bridge therapy to get your patient to a point where they can get the incisional surgery, and it's very lifestyle compatible for your very young patients, for your very old patients, for your physically restricted patients. I would like to talk about the continuous wave G probe at the end, just a couple more slides. This is definitely different setting compared to the Micropulse TLT. It has, but I reserve them for a little bit more severe diseases and also worse pre-op vision to start with. It does deliver a higher energy due to its continuous wave versus the pulse one that we use for the TLT, Micropulse TLT, and it has higher risk of CME or other inflammatory symptoms you can see in the eye. But it works well. I have a 70-year-old male with chronic angle closure, severe in both eyes, refractory to previous treatment. As you can tell, he's got an express shunt in the eye, in the right eye, express shunt, and 2 BGI in the other eye, or Barrel glaucoma implant in the other eye. Pressure not controlled. He's on all the preservative-free versions of eye drops you can think of. He developed severe ocular surface disease, including limbostem cell deficiency, so his cornea is very beat up, and he's on autologous serum tears already. He really wants to not use eye drops if possible. That seemed almost impossible given how severe his glaucoma is. He also has Parkinson's disease with very severe mobility issue, so applying the drops is an issue for him as well. So he was motivated to try anything he could to get rid of the topical drops. So I did the continuous wave on this patient with the G probe. So the setting typically I start is the 1250 4-second continuous treat and 24 spots on this patient. So post-op month 3, his pressure is 12 and 8, and on just 1 preservatives free of the eye drops out of the other ones he had. So after the surgery, his vision definitely improved significantly, probably from the improvement of not having to use so many drops. The surface really improved and no significant inflammation that I could see. So he was very, very happy. Another person that would definitely be on the testimonials if he needed to. So in summary, the Micropulse TLT can very effectively treat all kinds of glaucoma with very favorable safety profile. The safety profile and the fact that it's so versatile and post-op friendly, I really highly recommend that. TLT might be used in all severity levels of glaucoma, and it's very patient friendly, like I've been kind of emphasizing throughout this talk. The continuous wave CPC may also play a role in patients with more severe disease and probably worse pre-op vision. So with that, thank you, and I'll take some questions if you have. Great question. Initially I did. For my continuous wave, I do block them, but now I've been just doing propofol without blocking, and they do very well. So we just get them really deep. I thought about this. If I'm using propofol to block them, might as well just using the propofol to do it. So I do them at the ASC, so they get them really deep, and it really only takes 5 minutes with my setting, so they do very well without a block. Yeah, but I know it's painful. It's probably not okay to do them just in the clinic with this setting, to not do any anesthesia or propofol versus the block. They, even when they're sleeping, if they're not deep enough, I can see them really trying to fight against it.
Do you have a steroid regimen, post-op regimen?
Yeah, so I actually do a sub-tenons Kenalog afterwards, and then I don't really put them on topical steroids afterwards either. I put them on an NSAIDs. They do very well with that. Just a Prolensa once a day. Yep.
Question?
How do you decide what taper, for how much energy you're going to apply? What's your decision process on?
Yeah, so I think for the G probe continuous wave, I still titrate based on what I hear the pop really guides me. I do go up by 150 increments. If I see a pop, I come down immediately. But for the Micropulse, I basically do it based on the calculation of the total energy delivered. So I think with the 2500, 4 slow sweeps at 15 seconds per sweep gets you to that sweet zone. So I really don't titrate. I decide how much to start, either 2250 or 2500, based on the severity of the disease before I even go in. Intraoperatively, I don't titrate, if that's what you ask.
Any other questions?
So, are you starting to use it as instead of? Are you going to recommend some patients, rather than getting a third drop, say, why don't you do this instead?
I do.
Yeah.
I have patients. I give them that option. When I start the second drop, that's when I start with the QHS, Zalatan, or your Ropressa, I tell them about SLT. If they are already more leaning towards doing procedure, then this is a very easy sell to them. It's not really a sell, it's a recommendation. And then they take it because they really don't want to use that second drop twice a day and then a third one. So yeah, I think it's something you could start from the very beginning. Yeah. Yeah, with Micropulse, I have to say, knock on wood, I haven't seen any major CME in any of the Micropulse laser I treated. Continuous wave G probe, I do see them, which is why I'm leaning more towards the Micropulse if I really don't need to get that pressure really, really low to the single digits.
Patients that you have more than one drop, you would recommend?
I would consider this for sure, especially if these are patients that already failed the SLT before. Then it's easier for them to embrace the idea of having another laser procedure.
I have a patient that has moderate glaucoma. She's hesitant to proceed with any type of incisional surgery, and she has significant visual field loss. And I'm thinking, this is a place for this?
You should definitely try it. I have tried them in several of my patients where they're just so hesitant to go into surgery. If you know that they may eventually get into that incisional surgery, this is a great stepping stone to even get them to think about surgery. And at the meantime, you can actually achieve really good results, have low pressure to at least buy you time to get into that, where they still thinking about maybe they really need surgery.
What would you anticipate as the worst complication of Micropulse that you've seen, or is it more common in more pigmented individuals?
Yes,
less pigmented
definitely
individuals?
heavier pigmentation, more prone to have inflammation. But with the Micropulse setting, I still haven't seen AC cells. I've seen, but to CME level, I haven't. Yeah, so I was telling him earlier, I do a subtenon's Canalog injection at the end, so that really helps for you to know that the inflammation is controlled if it's there.
For the Micropulse ones? Or
For the Micropulse ones as well.
You're not concerned about like a postoperative spike in glaucoma?
A steroid spike, I haven't seen that. If these patients are getting these procedures, a lot of them had glaucoma procedures before or were on, or pseudophakic that's been treated on the steroid before, so they're not a steroid responder. I use Micropulse to treat steroid responders anyway. So if there is a problem, you can actually treat that. And I have done that where they had a steroid response. I either cut out the subtenons, which is not dissolved yet, or I actually take them back to an enhancement Micropulse treatment and not give steroids at that time.
How many procedures on average you're doing to achieve the end result on your patients?
Just most of my patients, only one. Maybe I can think of less than a handful that needed a second enhancement treatment. And for those patients are monocular, very fragile old lady who's very hesitant, I'm worried about CME, I tell them at the beginning I'm going very ginger the first time, and that would guide us if we need a second one. I just set the stage that way so they don't really get surprised that the laser failed. Yeah.
Terrific.
Great.
Thank
Okay.
you so much.
All right.
Appreciate it.
You're welcome.